So hello guys, welcome back to our channel. This is your Aditya Shinde. Welcome back to our channel. So आपका स्वागत है एक नए वीडियो में. इस वीडियो में हम एक कंप्लीट कोर्स लेंगे फॉर zygomatic implant and pterygoid implant by Dr Rajesh sir for zygomatic and Dr Antriksh sir and Dr के वो उन्होंने मुझे इतनी बड़ी अपॉर्चुनिटी दी. उनका पीजी का जो कोर्स है उसके लिए ब्रांड कोलेब्रेशन करने के लिए वो रेडी हो गए. उनका जो मैंने उनको अप्रोच किया था तो उन्होंने मुझे अप्रूवल दे दिया. एंड थैंक यू टू अमृता मैम और एचओडी ऑफ प्रोस्थोडोंटिक्स. तो उन्होंने मुझे इतने बड़ी अपॉर्चुनिटी दी. इट वाज अ वेरी नाइस एक्सपीरियंस. बहुत अच्छा था कोर्स. आप भी लेक्चर्स देखिएगा, उसकी सर्जरीज की वीडियोस है, मैं फ़ोटोज़ भी अपलोड करने वाला हूँ. वो सारी चीज़ें आप देखिएगा. इट विल बी वेरी क्रूशियल एंड बेनिफिशियल फॉर यू. और ये कोर्स मोस्टली हमारे कॉलेज के पीजीज ने किया था. इट इज़ अ पेड कोर्स बट स्टिल आई एम गिविंग यू दिस कोर्स फ्री ऑफ कॉस्ट बिकॉज दिस इज़ माई इनिशियल फेज एंड आई वॉन्ट योर सपोर्ट फ्रॉम दिस वीडियोज़ गाइज. सो प्लीज़ सपोर्ट. आप सर का रिव्यू भी देखिएगा. ठीक है. थैंक यू गाइज. थैंक यू सो मच फॉर वॉचिंग दिस वीडियो. बाय.
I will be mostly talking about zygomatic implants, and Dr Antriksh will talk about pterygoid implants. It is just a segregation so that we can share our knowledge. So nowadays we can see a lot of clinical problems. Patients are also aware about their health. They want to look good, they want to have good function. And we have many options now available, and patients also have a good capacity for learning and understanding. So we always see in our private practice or in the institutional practice atrophic maxillae. Most of the times the patients are without teeth for longer time. They are very dangerous for longer time, and eventually, as we know, as the bone is when the tooth is removed, there is a bone loss. The bone loss is continuous, but especially in maxilla, we have something called a sinus. Now, when the bone is lost, when the bone is losing, the sinus also mimetizes. So we have double effect. Mandible also equally resolves. At times resolve more than maxilla. But because of the sinus presence, there is a double effect. There is a mimetization of the sinus overall, there is a bone loss. In addition to this, the bone quantity and quality here is bad. All of us know T1, T2, T3, T4. According to the density of the bone, we have this classification. This bone is T4 bone. So the quality of the bone is bad, quantity of bone is also bad. In addition to that, we have sinus effect. So most of the times we have less in bone available for regular conventional implants. So we shift to something called as all-on-4 or tinted implants. Sometimes that also doesn't work. So we need to have something additional from a basal bone, not from the angular bone. This is what the conventional implants are going to go into the angular bone. So as the angular bone is lost, and if there is minimal or no angular bone, we have no option, and we have to think beyond the angular bones. So as I told about sinus mimetization, it is standard. It happens as the age advances, and once the teeth are lost, it is multifolded. Poor denture retention. If the patient is freshly come to you with atrophic maxilla, yes, then the denture is not possible many times. Or if the patient is waiting for longer time, this denture. Quality of life is bad because the patient is not able to eat anything. So patient is always unhappy. Patient wants to look better. Nowadays patients want to look younger and better. Obviously, they have a right to look younger and better and have good function. So they want to eat food. Obviously, they need to be rehabilitated. So once when the patient is reported to us, we have so many options. When the maxilla is edentulous, so we can obviously do the age-old complete denture for years together. We are doing that. We have, if that is not possible, if you want to do something better than that, we can do sinus augmentations procedures, where the sinus, for example, is the residual bone, the alveolar bone is less, and there is a sinus there very close to the alveolar bone. For instance, if it is say 4 mm, 5 mm, you cannot place the implant directly. We have to place a longer implant. So how will you do that? You have to lift the sinus up. So there you have to do bone grafting. Sinus lifts around 2 types, direct and indirect. We have few indications for direct and indirect. So here we can do artificial bone grafting with autogenous bone graft, and we expect the bone formation there, and then we place the implant. Obviously there again waiting period is there. In zygoma, waiting is not there immediately because you are placing in the basal bone. So there is no waiting as far as the implant placement is concerned. Right from the beginning also there is no waiting period. You can do some aggressive procedures like onlay bone grafting procedures. Now how to go back? Some extra procedures like you can do leaf or osteotomy. You can osteotomize the maxilla downward, forward, or wherever you want to put it, and put some autogenous iliac bone grafts or a rib bone grafts. So these are all extensive advanced procedures which need to be carried out under general anesthesia, and it has its own donor side morbidities and other complications. So these are all challenging surgeries. Usually patients are not, they don't desire such procedures. They are not normally interested in such procedures. So finally we have something called as pterygoid or zygomatic implants, which are now really popular. We are doing it under local anesthesia as an office procedure or OPD basis. Again, the same man was responsible for these zygomatic implants, Ahilyanagar. It was first done for the receptive defect. It was done when the maxilla was receptive for some tumor. But then now the indication is completely changed. We are doing it on the routine basis for severely resolved maxillary failed grafting. You can try sinus flow elevation and sinus lift procedures, but sometimes that fails. That the last option which remains is zygoma pterygoid implants. And the biggest advantage here is immediate loading. Sometimes the patients want immediate, at least temporization or a temporary replacement. So that is possible only with implants which are really strong. Strong means they have a good anchorage and there is a good primary stability and they are in a strong bone. As I told you, maxilla is not strong. It is a T4 bone, soft bone. So it is not going to give you good strength for temporization. So a lot of publications have happened, but we have around 2000 to 2010 extra sinus techniques were explained, but the latest is something called as Saga concept. I will be coming to that. And currently we are doing a lot of digital planning, navigation, surgery, and dynamic guide placement. So that is again a good different topic altogether. Dr Antriksh will definitely highlight on this. He is the guy who is planning all my cases when I am operating anywhere in India. So he is very good in this. Obviously, you know the DICOM data is transferred. We take it from the center and we do the digital planning and we have a digital workflow. So what is the zygoma implant or zygomatic implant? It's a long implant, very important, long implant anchored in the zygomatic bone, bypassing the deficient alveolar maxillary process. So we are not engaging the maxillary process, we are engaging the zygoma. Implant is in the mouth here, in the angle. It is bypassing the alveolar bone as well as sinus and engaging the zygoma. That is the point, last point that it is engaged. This is the only rough part in the implant. Even new designs, they explain later. So these are long implants because normal implants are 10, 12, 14 size of implants which we use for alveolar bone. Zygoma implants are very long because they have to traverse from here to there. So basically, they engage the rough surface engages the sinus, zygoma completely. So anatomically, I just brief you something about zygoma. So what we see, even though this is pendulous, just imagine if it is very jealous, I got this diagram from the book. So we'll have a residue of gills, no teeth present, totally residue of gills. Sinus walls, especially the sinus rotolateral anterior sinus wall, which is seen when we see the front part of the zygoma.
Over here, professor dentist, and we have Dr. professor dentist, HOD, department of professor dentist. Then we have Dr. Rajesh, senior oral surgeon. Today we have conducted a course on zygomatic and pterygoid implant placement with live surgical placement in patient and demonstration and hands-on on dummy models. We hope that this helps the student to learn newer and advanced implantology technique. We thank all the participants who are enthusiastic participate in the course. Thank you, and please subscribe to the channel of Dr.
Aditya Shinde. Yes. Thank you. हेलो गाइस, वेलकम बैक टू योर चैनल. दिस इज योर सर आदित्य शिंदे. तो आज हमने एक कोर्स किया ऑफ zygomatic pterygoid इम्प्लांट्स का कोर्स किया अपने ही कॉलेज में, YCDC डेंटल कॉलेज में. और बहुत सारे दोस्त स्टाफ थे, डॉक्टर्स मुंबई से आए थे स्पेशल, उनका ओरल सर्जरी में ये हुआ है, MDS हुआ है. और हमारी प्रोस्टोडोंटिस्ट की MDS स्टाफ डॉक्टर अमृता भाटिया मैम भी, उन्होंने भी बहुत सपोर्ट किया मुझे कोर्स में लाने के लिए. थैंक यू सो मच फॉर योर सपोर्ट. इट इज़ वेरी प्लेजर फॉर मी. तो ऐसे हम आगे कंटिन्यू करेंगे. थैंक यू सो मच.